Okay, to the last, almost the last part of cardiology, valvular abnormalities. The first thing that comes is infective endocarditis. The strongest risk factor for developing infective endocarditis is the previous episode of endocarditis. Okay, other factors would include previously normal valves, 50% rheumatic valve disease, 30% prosthetic valves, congenital heart disease. Intravenous drug users can also cause some problems. Hypertrophic cardiomyopathy. So most common cause of endocarditis is a very common question. Um, Streptococcus viridans. Okay, most common cause of endocarditis, Streptococcus viridans, very common. Staphylococcus epidermis. Epidermidis if less than 2 months post valve surgery. So these two questions really always come in MRCP Part 1. Very common question. Most common viridans and post surgery less than 2 months epidermidis, staphylococcus epidermidis. Okay, causes of infective endocarditis, Streptococcus viridans, the most common, has good prognosis though. Staphylococcus epidermidis, prosthetic valves. Staphylococcus aureus, usually acute presentation in intravenous drug users, is also something comes in the exam very often. And this one as well, Streptococcus bovis, is also related, associated with colorectal cancer. So whenever you see a question talking about colorectal cancer and infective endocarditis, you have to think about Streptococcus bovis. Okay, bacteroides fragilis endocarditis is a very rare complication of colonic resection. Bacterial-rich heart valve via venous return. This is why it affects the right, then the left. Then you treat it with metronidazole. Non-infective SLE, malignancy, marcantic endocarditis. Culture negative cause. The culture negative causes brucella, prior antibiotic therapy, Coxiella burnetii, Hasseg group, that is Haemophilus, Actinobacillus, Cardiobacterium, Legionella, Kingella, Bartonella. These. Okay, following prosthetic valve surgery, Staphylococcus epidermidis is the most common organism. We've spoken about that before in the first 2 months, and is usually the result of perioperative contamination. Very important. After 2 months, the spectrum of organisms which cause endocarditis return to normal. So the organisms return to normal, except with a slight increase in Staph aureus infection. So what these two are the ones you need to remember all the time. The rest are there as well. Okay, so infective endocarditis, what's the diagnosis? How to diagnose this thing? There's a criteria called Duke's criteria, the pathological criteria, positive or 2 major criteria, or 1 major and 3 minor or 5 minor. Either of these, you have infective endocarditis. Pathological criteria, what is that? Positive histology or microbiology of pathological material obtained at autopsy or cardiac surgery. So biopsy, as in histology, has to match, has to be positive. During cardiac surgery, you can have valve tissue vegetations, embolic fragments, or intracardiac abscess content, which you can do pathology test. What are the major criteria? 2 positive blood cultures showing typical organism consistent with the infective endocarditis, such as Streptococcus viridans and the Hasseg group, or persistent bacteriemia from 2 cultures taken 12 hours apart. So 2 positive blood cultures, or 2 cultures taken 12 hours apart, or 3 or more blood cultures where the pathogen is less specific, such as Staph aureus and Staph epidermidis. So the first one was for viridans and Hasseg group. The second one is for Staph aureus, Staph epidermidis. Positive serology for Coxiella burnetii, Bartonella species, or Chlamydia pescetacea. Positive molecular acid for specific gene targets. So these are for positive blood culture. Evidence of endocardial involvement is also important for major criteria. One is culture, and the second one is evidence of endocardial involvement. How do you know? It's just echocardiogram. Positive echocardiogram, oscillating structures, abscess formation, new valvular regurgitation or dehiscence of prosthetic valves, or new valvular regurgitation. What are the minor criteria that I look for? Definitely predisposing heart disease, fever of more than 38. Microbiological evidence is the major criteria. Vascular phenomenon covers this. Vascular phenomenon includes major emboli, splenomegaly, clubbing, splinter hemorrhage, petechia or purpura. Immunological phenomena, glomerulonephritis, Osler nodes, rot spot, elevated CRP or ESR. These are all minor criteria. So 5 of these minor criteria, or 1 major and 3 minor, or 2 major, or pathologically criteria positive, you have endocarditis. Okay, what are the poor prognostic factors for this? Staph aureus is basically poor prognostic. Good prognosis, streptococcus viridans, good prognostic factor. Staph aureus is bad. Prosthetic valve, especially early echo during surgery. Culture negative endocarditis, that is the HASSE group. We've talked about the culture negative ones, this HASSE group, and then Coxiella, Brucella, all these things, Bartonella. All these have poor prognostic factors. Okay, all these are poor prognostic factors. Culture negative endocarditis, low complement levels. Mortality according to organism, Staphylococci 30%, Streptococci 5%, per organism 15%. That's how you see its poor prognostic feature, Staphylococci. Current management guidelines, what do you do for it? Native valve endocarditis, that is blindly give amoxicillin or ampicillin, consider adding low dose gentamicin. So amoxicillin and gentamicin, that's for endocarditis. AG written here. Penicillin allergic or MRSA suspected. If the patient is allergic to penicillin or MRSA suspected, vancomycin and low dose gentamicin. So G is still common there. If severe sepsis with risk factor for gram-negative infection, use vancomycin and meropenem. Both of them. Gram-negative infection. Staphylococci, flucloxacillin. Vancomycin plus rifampicin if penicillin allergic or MRSA. Streptococci, benzyl penicillin plus gentamicin. So BG. Here it's F. Okay, so pen alone is fully sensitive. Pen would be benzyl penicillin. Prosthetic valve endocarditis, blindly give vancomycin, rifampicin, low dose gentamicin. So VRG for prosthetic valve. All these you need to remember because these often come in the exams, so you need to remember by heart. Okay, what are the indications for surgery in case of endocarditis? Severe valvular incompetence, early prosthetic valve endocarditis, aortic abscess indicated by prolonged PR interval on ECG, infections resistant to antibiotics, cardiac failure refractory to standard medical treatment, recurrent emboli after antibiotic therapy, HASSE group, Brucella, Coxiella, pseudoaeruginosa, and vancomycin resistant enterococci. All these things might be indications for surgery. Especially the first few are very important and common. The next thing that comes up is still the guidelines. Following procedures do not require routinely prophylaxis, like dental procedures, upper and lower GI tract procedure like endoscopy, colonoscopy, genitourinary tract. This includes urological, gynecological, obstetric procedures in childbirth, upper and lower respiratory tract infection. Upper and lower respiratory tract procedures like bronchoscopy. Chlorhexidine in mouthwash should not be offered as prophylaxis against infective endocarditis to people at risk of infective endocarditis undergoing dental procedures. The guidelines do, however, suggest any episode of infection in people at risk of infective endocarditis should be investigated and treated promptly to decrease the risk of endocarditis developing. If a person at risk of infective endocarditis is receiving antimicrobial therapy because they are undergoing a GI or genitourinary procedure at a site where there is suspected infection, they should be given an antibiotic that covers organisms that cause infective growth. So it has to be covered. That's the main rule. Okay, moving on to the next thing. Next topic is aortic stenosis. It's a very important topic, very important one. So let's see what's there. What are the features? So firstly, I want to say one thing that for stenosis, you have to remember that the valves don't open properly, and for regurgitation, the valves don't close properly. So what happens during aortic stenosis is the valves are narrow, the opening is narrow, it doesn't open properly. So what happens? Let's see. Features can be narrow pulse pressure is low, the difference between diastolic and systolic basically. Slow rising pulse, delayed in systolic murmur. Of course, during systole the murmur will take place because it's like going from the aorta, the blood. During systole, absent or soft S2 because the valves are a bit like not opening much. S4 thrill, duration of murmur, left ventricular hypertrophy or failure. because since its stenosis is there, the blood pulls back and causes hypertrophy of ventricular muscle over time. So in aortic stenosis, what are the causes? Degenerative calcification. Most patients are in elderly age, so aortic stenosis, you will see that most of the cases are from like people of old age. Bicuspid aortic valve, most common case caused in younger patients. So bicuspid aortic valve, it looks like this, two valves. Usually it's normal tricuspid valve, usually aortic stenosis. Bicuspid is like two valves, two leaflets as in. Okay, Williams syndrome, post-traumatic disease, subvalvular HOCM. Okay, aortic stenosis management, AVR if symptomatic, aortic valve replacement as in if symptomatic, otherwise cutoff is gradient 50 millimeter. Okay, we'll come into that. Now there are some part 2 tips here. May go through it. First we go through management. If asymptomatic, then observe the patient is general rule. Don't do anything if it's asymptomatic. If symptomatic, then valve replacement. If asymptomatic but valvular gradient is more than 50, as in the pressure before and after the valve is more than 50, and with features such as left ventricular systolic dysfunction, then consider surgery. So the difference, if it's more than 50 and then there's systolic dysfunction, that's when you consider surgery. Balloon valvuloplasty is limited to patients with critical aortic stenosis who are not fit for valve replacement. Okay, so let's do that. And there are some part 2 tips which may not go. If you want, the bitumen echo is used to assess the rate of AS. Patient with more than 20% increased stroke volume after vitamin means better prognosis post surgery compared to the. Okay, and then there's left systolic dysfunction will result in a decreased flow rate across the aortic valve and hence a quieter murmur. So if we're already having left systolic dysfunction, like your ejection fraction is already low and you have aortic stenosis, there's a quieter murmur and lower gradient on echo. This will underestimate the degree of stenosis, okay, because of the decreased systolic function. Okay, Hades syndrome is something for part 2, but still we can go through it. Well-known association between microcytic anemia and calcified aortic stenosis. The treatment is to replace the valve, as the mechanism is thought to be due to destruction of the von Willebrand's factor as the platelets traverse the stenos valve, resulting in bleeding per rectum. Investigation of choice after valve AVR is mesenteric angiography, as the bleeding vessels are poorly visualized on the colonoscopy. This will look for the presence of angiodysplasia, which may be associated with aortic stenosis. Resection of the diseased bowel has always been prescribed as a treatment. Association with AS is thought to be due to microangiopathic hemolysis. Hemodynamic optimization prior to surgery with blood transfusion is preferred, but this would not depend on the surgeon. Okay, this is something not needed right now. If you want, you can skip it. Next is aortic regurgitation. We have been studying all this from MBBS level or bachelor's level. So all these are like not very new topics, but these are complicated topics which you may forget. You keep on forgetting every day. Aortic regurgitation, as I've said, the valves don't close that much. The features would be early diastolic murmur because it's during feeling of the ventricles. That's when it's not filling of the ventricles. It's often after systole that you see this murmur because the valves are not closing well enough. So early diastolic murmur. Collapsing pulse, wide pulse pressure, significant difference between systolic and diastolic. It's just the opposite of aortic stenosis. Mid diastolic Austin Flint murmur in severe AR due to partial closure of the anterior mitral valve cups caused by regurgitation streams. Okay, what are the causes of aortic regurgitation? Rheumatic fever, infective enterocolitis, connective tissue disease like RASLE. These are very much involved in this. Causes can be also due to aortic root disease like aortic dissection, spondyloarthropathies, ankylosing spondylitis, hypertension, syphilis, Marfan's disease. Okay, part 2 tip is also there, and then PACES tip is also there, which are like far-fetched, but now we can just check it out. LVF management asymptomatic with LVSF more than less than 50% dilated LV, consider replacement. And there are some signs which are necessary for PACES, but we can still study for AR. Corrigan sign, visible and vigorous arterial pulsation in neck, that's called Corrigan sign. Demoset sign, head nodding due to the arterial pulsation in the neck. So collapsing pulse, as you've seen here in the neck, the pulsation causes nodding of the head. Queen sign is gentle and subtle pulsation of the capillary belt in the nails, and Torosius sign is diastolic murmur proximal to the femoral artery compression. Moving to mitral valves prolapse. Okay, it's common. It's occurring in about 5 to 10% of population. Usually idiopathic, but may be associated with a wide variety of cardiovascular disease. Whatever associations you have to remember: congenital heart disease like PDA and ASD, cardiomyopathy, Turner syndrome, Marfan syndrome, Fragile X syndrome, osteogenesis imperfecta, so WPW, long QT, pseudoxanthoma elasticum. So many associations for mitral valve prolapse. What are the features that you see in mitral valve prolapse? The patient will complain of atypical chest pain, or was this prolapse? So chest pain or palpitation, mid systolic click, something unique. Late systolic murmur as well, longer if patient standing, and this is for if patient squatting. Complications might be mitral agitation, arrhythmias, long QT, emboli, sudden death. What are the management for this? Mostly you will think of surgery maybe, or some sort of repair. Patients more than 75 years who are in atrial fibrillation or left ventricular failure impairment should be referred to surgical assessment as early as possible. TOE, transesophageal echo, can tell if the valve is for repair or replacement. Can be done intraoperatively as well. Follow-up is crucial, as 15% of MVP patients develop the most serious complications out of 15 years of ring prolapse, TIA, ischemic strokes. Mild to moderate MVP with normal VSF, beta blockers, and echo follow-up. Another topic that comes up very often is mitral regurgitation. The valves don't close that well. It's a common valvular disorder that can arise from abnormalities of any part of the mitral valve. Leaflets, annulus, or chordae, or papillary muscle, and can also be caused by abnormalities in the left atrium and ventricle. Can also cause it. Classification: primary cause of mitral valve disease like mitral prolapse. This can cause MR. It's written here as well. I see. Okay. Can be caused by mitral valve as well. Here, complications. Secondary cause can be caused by ischemic heart disease leading to functional MR due to fibrosis of the chord or because of MI. So, fibrosis can also be a reason why the valves don't close very well. Infective endocarditis is also known as a known cause of MR. Okay, what happens in MR actually? It doesn't close. So, what really happens? It's actually so in MR, it's actually a pan-diastolic murmur. Here's a mistake here. It's a pan-systolic murmur. It's a mistake here. It's not diastolic, because when systole is taking place, that's when the blood flows back as it's having regurgitation in mitral valve. It flows back. If the valve doesn't close, it flows back. So that makes a sound during systole. Pan-systolic murmur best started at the apex. So the mitral valve, so it's apex. Radius to the axilla, loud and severe. Murmur increases by squatting, leg raising, or lying down. More venous return and blood flow across. This is valve louder murmur. Thrilling apex beat. So it's mitral, so it's all about apex. Indication for surgery: the general approach is to wait and watch it. Echo every 6 to 12 months, then decide to intervene. Depends largely on patient's symptoms and abilities. What are the indications? Symptomatic, moderate to severe MR. Development of SV, systolic dysfunction. Development of AF. Indicates left chamber morphology change due to MR. Development of pulmonary hypertension, even if asymptomatic. So it happens due to backflow of blood to the lungs from the heart. Okay. Well, mitral stenosis is another topic which is very important. Causes of mitral. It's said that the causes of mitral stenosis are, in fact, rheumatic fever, and rheumatic fever. Rare causes may be seen in the MRCP, including mucopolysaccharide, carcinoid, endocardial fibroelastosis. These features are there for almost like the whole time in MBBS or in bachelor's. They've studied them already. Mid-diastolic murmur, stenosis. So during diastole, the blood passes from left atrium to left ventricle via the mitral valve. So if it's stenosed, it's making some noise. Mid-diastole, there's a noise. There will be loud as one. When the valve closes, opening snap. Low volume pulse, manual flash, atrial fibrillation might be a feature as well. Features of severe mitral stenosis: length of murmur increases, opening snap becomes closer to S2. Echo would be like normal cross-section area of the mitral valve is 4 to 6, that is normal, 4 to 6, but a tight mitral stenosis implies a cross-section area of less than 1. Okay, what we can do about it? Percutaneous balloon valvotomy is treated severe MS. Balloon valvotomy, it's contraindicated in concomitant moderate to severe mitral. So in severe, you don't really use that. It's for sorry, it's not for severe regurgitation, as in mitral stenosis. You use this one, okay? Percutaneous balloon valvulotomy, contraindicated in severe mitral regurgitation, left atrial thrombus or heavily calcified mitral valve, concomitant coronary artery or other valvular disease requiring surgery. I'm ignoring this as part 2 tip. Tricuspid regurgitation. Well, you know the valves don't close, as I said, regurgitation. For tricuspid regurgitation, of course, there will be what kind of murmur? Of course, it's a systolic murmur because blood flows back. Pansystolic, like throughout the systole. Giant V waves in the JVP and pulsatile hepatomegaly, left parasternal heave. So this will cause all the right-sided complications that you see. Signs will be there. Cause are right ventricular dilation, pulmonary hypertension like COPD, rheumatic heart disease, infective endocarditis, especially IV drug users, Epstein anomaly, carcinosin. The associations that you have to remember, for tricuspid regurgitation and mitral valve prolapse, there's like too many associations. Mitral regurgitation, AR, all these are having too many associations. Now let's talk about something that is very common: prosthetic valves. The most common valves which need replacing are the aortic and the mitral. These are the ones used the most, and they are needed to be replaced. Sometimes there are two main options for replacement: biological, or it's the same as bioprosthetic. So when they call prosthetic valves or bioprosthetic valves or biological, is the same thing. Or mechanicals. Mechanical is different. Now biological prosthetic, usually bovine or porcine in origin. The major disadvantage is structural deterioration and calcification over time. So the structure gets worse. Calcification. So the structure gets worse. This calcification. This is the main disadvantage for a bioprosthetic or biological valve. Most older patients, more than 65 years for aortic valves and more than 70 years for mitral, receive a bioprosthetic. So older patients, it's better. The good thing is that long-term anticoagulation not usually needed. Warfarin may be given for 3 months, so you don't need anticoagulation. Although structural deterioration takes place, but then depending on the patient factors, low dose aspirin is given long term. So aspirin would be good enough for this kind of patients, and we usually give it to the elderly patients, and anticoagulation is not needed. So for everything that you study, you need to make some checkpoints like that. You really need to know. Like for bioprosthetic valves, you don't need anticoagulation. Number 1, low dose aspirin is good enough. Number 2, it's for elderly population. Number 3, number 4, disadvantages: structural deterioration and calcification. And then the next one is mechanical valves. The most common type now implanted is the biliftlet valve. Biliftlet looks like this. Ball and cage valves are rarely used. Biliftlet valve is the one. Mechanical valves have a low failure rate, so that's a good thing. Low failure rate. Major disadvantage is increases of thrombosis. So this is a problem. Meaning low-term anticoagulation is always needed. So you need to always check the INR of the patient. Okay, with VK only SDO is not suitable. Aspirin is normally given unless there's a contraindication. So target INR is very important. Aortic valve is 2 to 3, mitral is 2.5 to 3.5. Following in the guidelines for prophylaxis of endocarditis are no longer needed for dental work. Prosthetic valve thrombosis. So this complication occurs in 0.03 to 5.5% annually, with equal frequency in bioprosthesis and mechanical valve. It's more common in mitral prosthesis and subtherapeutic anticoagulation. This resulting in shock. Okay, prosthetic valve thrombosis. The diagnosis, best diagnostic modality is echo, transesophageal echo. Transthoracic echo is the initial choice in sick patients, and if adequate visualization is not obtained, TEE can be done. So management would be thrombolytic therapy in pulmonary edema or hypertension. In stable patients, surgery is a better option for left-sided PVT, pulmonary thrombolism, while right-sided PVT should be treated with thrombolytic agents. Serial echocardiography should be performed. Response is inadequate, and repeat thrombolytic therapy can be given. Alright, we are moving to the other sector of cardio, almost the end. Not really, but almost there. The major vessel abnormalities. I don't want to prolong and make another part for this topic. Okay, so major vessel abnormalities, aortic dissection. Okay, dissection, it can present with a very painful scenario. Patient may present with chest pain, so yeah. Okay, so aortic dissection present with severe chest pain and tearing pain. Patients are usually screaming because of the pain, unable to sit or lay down. So two types of aortic dissection are there. One is type A, ascending aorta, and one is type B, descending aorta. So ascending aorta, if there's dissection there, tear over there, control your BP and surgery may be needed, and using labetalol. And for descending aorta, control will be by labetalol. Type A is ascending aorta, 2/3 of the case, and type B is descending aorta, distal to left subclavian origin. Management is surgical management for type A, but blood pressure should be controlled into a target systolic of 100 to 120 while awaiting intervention by labetalol. And type B, conservative management, bed rest, decrease blood pressure by IV labetalol to prevent progression. Surgical repair can be considered in some cases only. Okay, what are the associations here for aortic dissection? Hypertension, of course, can be a major cause. Trauma, bicuspid aortic valve, collagen like Marfan syndrome, Ehlers-Danlos syndrome, Turner-Lewin syndrome. There are associations as well. You need to remember all these. Pregnancy and syphilis. Okay, complications of backward tear, complications of forward tear. Backward tear would be aortic regurgitation, MI, inferior pattern often seen due to right corner involvement. Complications of forward tear, unequal arm pulses and BP. Remember this. Stroke and renal failure. Okay, the next thing that are there are very important topics and need to be revised very well, because topics, a lot of questions come from here. One is primary pulmonary hypertension or idiopathic pulmonary arterial hypertension. It's like secondary cause of pulmonary hypertension includes COPD, congenital heart disease, Eisen-Menger syndrome, recurrent pulmonary embolism, HIV sarcoidosis. So primary pulmonary hypertension, PPH, or now IPAH, what are the causes? What happens really? Pulmonary arterial pressure is more than 25 at rest and more than 30 with exercise. PPH is diagnosed with no underlying cause can be found. Around 10% of cases are familial autosomal dominant. Endothelin thought to play a key role in pathogenesis, so the management can be its antagonist associated with HIV, cocaine, and oxygens. Features will be more common in female, typically present at the age of 20 to 40-year-old. Progressive shortness of breath will be there. Cyanosis, right ventricular heave. Okay, what are the features? The signs that they are right ventricular heave, loud P2 because pulmonary valve is involved. Right ventricular heave, P2, raised JVP, prominent A-wave atrial contraction, tricuspid regurgitation. Management would be diuretics if right heart failure, anticoagulation, vasodilator therapy, calcium channel blocker, IV prostaglandins, bosentan, like endothelin receptor antagonist, heart lung transplant. Pregnancy is absolutely contraindicated, very high risk of mortality. So this is something you have to know. This was primary pulmonary hypertension, and this is pulmonary arterial hypertension. May be defined as sustained elevation in mean arterial pressure of greater than 25 at mean. Isn't it the same thing? Mean arterial pressure? No, it's pulmonary arterial pressure. This is the mean arterial pressure. No, greater than 25 millimeter mercury at rest and 30 after exercise. PAH has recently been classified by WHO, Group 1. So it's depending on what it's connected with. Group 1 will be pulmonary arterial hypertension, idiopathic, familial, associated with conditions like collagen vascular disease, congenital heart disease, systemic to pulmonary shunts, persistent pulmonary hypertension in the newborn. Group 2 is related to left heart disease like left side atrial, ventricular, valvular disease, the left ventricular systolic and diastolic dysfunction, mitral stenosis, mitral regurgitation. Group 3 is related to lung disease, very important: COPD, interstitial lung disease, sleep apnea, high altitude. Group 4 would be related to chronic thromboembolic diseases like sickle cell, polycythemia, pulmonary hypertension due to clot and other disorder, lymphangiomatosis secondary to sarcoidosis or carcinomatosis. While echo may strongly point towards a diagnosis of pulmonary hypertension, all patients need to have a right heart pressure measured. Right cardiac catheterization is therefore the single most important investigation. So questions like this might come as the single most important investigation. Management should involve treating any underlying conditions. Following this, it has now been shown that acute vasodilator testing is central to deciding on the appropriate management strategy. Acute vasodilator testing aims to decide which patient shows significant fall in pulmonary arterial pressure following the administration of vasodilators such as intravenous epoprostenol or inhaled nitric oxide. So vasodilator causing a fall. If there is positive response, oral calcium channel blocker. If negative response, then endothelin receptor antagonist or phosphodiesterase inhibitor, prostacyclin analog can be given. And to the last section of cardiology is congenital heart disease. So in congenital heart disease, we have already studied from childhood from bachelor's, that there is like cyanotic and acyanotic. So this is something which keeps on coming back even in MRCP. So cyanotic TGA, transposition of the great arteries, is the most common at birth. That's what you have to remember. Cyanotic, fallow, and TGA. So I think you just need to remember with a mnemonic like TF. I won't be saying the word, but you can like keep it in your head. TF for cyanotic. And acyanotic VSD is the most common cause. So acyanotic, remember it's VSD, it's AV. And TF, you can remember that easily. TF is more common than transposition of great arteries. So tetralogy of Fallot is the most common one, but at birth TGA is the most common one. Fallow doesn't usually present until 1 to 2 months. So fallow presents after 1 to 2 months following the identification of murmur or cyanosis. In newborn, TGA is the most common presenting cause of cyanotic congenital heart disease. So again, cyanotic, you see, I said TF, that is tetralogy of Fallot, TGA. But there are other things like tricuspid atresia and pulmonary valve stenosis as well for cyanotic heart disease. And for acyanotic, is the most common is VSD. Next comes is ASD. Also have to remember these things like PDA, coagulation of aorta, aortic stenosis. So acyanotic involves a lot of things. Cyanotic, only thing is to remember is just this two, and the rest will be for acyanotic. So VSDs are more common than ASD. However, in adults patients, ASDs are more common. New diagnosis as the present later. So ASD, VSD are both acyanotic disease. Just remember this. This is like gonna be in the exam for sure. TGA at birth, fallow, most common cyanotic, and acyanotic is VSD. Fallow will be presenting after 1 to 2 months post birth. Okay, VSD, the most common cause of congenital cyanotic congenital heart disease. They close spontaneously around 50% of cases. That's great. Non-congenital cause include post-MI. Features will be a pansystolic murmur, which is louder in smaller defects. Complications can be aortic agitation, infective endocarditis, Eisenmenger complex, right heart failure. Okay, this is part 2 tip. I don't want to follow that. And aortic regurgitation is due to a poorly supported right coronary cusp, resulting in cusp prolapse. So we are talking about aortic regurgitation related to VSD. Okay, for atrial septal defect, it's also a cyanotic disorder, happens more in adulthood, as written here. They carry a significant mortality, with 50% of patients being dead at 50 years. Okay. Two types of ASDs are recognized: ostium secundum, ostium primum. Okay, before that, we have a picture here. You can show here that it's ostium secundum is when there's this ASD at the bottom of the septum of the atrium, and the secundum is like at the top. So ostium secundum, that is in the top, is the most common. Okay, what are the features for ASD? Ejection systolic murmur. Okay, ejection systolic murmur, fixed splitting of S2. Embolism may pass from venous to left side of the heart, causing a stroke. Okay, that's dangerous. Right heart catheter will show increased oxygen saturation in the right atrium, since there's like a hole in between. So of course, the blood passes out, and from in the right atrium it's supposed to be like low oxygen, but it shows high oxygen. Compared to vena cava. Normally, blood gets oxygenated only after leaving right ventricle to the lung and comes back to left atrium. And if there is a septal defect between atria, oxygen blood leaks from left to right. Thus, oxygen increase in RA. Okay. Oxygen secondum, 70% of ASDs will have this. It's more common, as I said. It's at the top of the septum. Associated with Holt Oram syndrome, no need to know. ECG will show RBB, right bundle branch block with right axis deviation. Usually treated with device, interventional closure if very large may require surgery. Just need to remember what are the features and what happens. Ostium primum primarily present with earlier than ostium secondum defects associated with abnormal AV valves, not the location of primum ASD. ECG will show RBBB with LID, prolonged PR interval. Let's remember that. Patent ductus arteriosus. Okay, this is also a cyanotic presentation, congenital heart defect. Connection between the pulmonary trunk and the descending aorta. As you can see here, pulmonary trunk, it will be connected with this is supposed to close at birth, but doesn't close. That's PDA. So what happens is this deoxygenated blood moves to the aorta. That's the bad thing. It's a cyanotic as well. More common in premature babies born at high altitude or maternal rubella infection in the first trimester. This is where the PDA can occur. So you really need to understand the pathophysiology so that you can work on the more details. What can be the features? Subclavicular thrill, continuous machinery murmur as blood continues to move from the pulmonary trunk to the descending aorta. Large volume collapsing pulse might be there. Wide pulse pressure might be there. Wide pulse pressure like in aortic regurgitation, wasn't it? Having apex speed, dilated LV. Okay, endomethacin closes the connection in majority of the cases. If associated with another heart disease, then prostaglandin E1 is useful to keep the duct open until after surgical repair. So endomethacin is what you use to close the thing, the hole. Next is patent foramen oval. Okay, it's present in around 20% of population. May allow, it's like in between the arteries, atriums. May allow embolus to form DVT to pass from right side of the heart to the left side, leading to a stroke. A paradoxical embolus is the most common cause of stroke following DVT. Do transesophageal echocardiography if echo failed to detect a PFO. There also appears to be a association between migraine and PFO. Some studies have said, okay. So people with having a patent foramen oval might have migraine as well. The association is there. Now, coarctation of the aorta. We're almost near the end. Coarctation of the aorta. What happens is basically here's the diagram. Is like you see coarctation of the aorta. Describes a congenital narrowing of the descending aorta. This happens in the descending aorta. It's more common in males, and despite association with Turner syndrome, surgical replacement is repair is the treatment. But even with repair, sometimes it reoccurs again. Mortality depends on the early diagnosis with 90% survival. If diagnosed in childhood, as low as 20% survival. Diagnosed, okay, whatever. What are the features that you need to know? Infancy heart failure, of course. Adult hypertension, radiofemoral delete for sure, because in the descending aorta, so of course there will be difference in the arm and legs pulses and flow as well. Significant BP difference between arm and legs, obviously. Mid-outlet systolic murmur, maximal overblack, apical click from the aortic valve. Notching of the inferior border of the ribs, color, Doppler BP measurement, difference between upper and lower. It's the same thing again and again. What are the stations you need to know? Turner syndrome, you see these kind of things. Bicuspid aortic valve, Bay aneurysm, neurofibromatosis, CAD. But this is the one congenitally connected. Next thing is Eisenmenger. Eisenmenger syndrome is characterized by reversal of the left to right shunt due to pulmonary hypertension. So left to right, becomes right to left. So blood from the right ventricles move to the left ventricle due to septal defect, of course. The original murmur may disappear once this develops. Original murmur may disappear cyanosis, of course, because the deoxygenated blood is moving towards the left ventricle, so the whole body is getting deoxygenated blood. Clogging, right ventricular failure, hemoptysis, embolism associated with VSD, SDPDA. Heart lung transplantation is required. Bicuspid aortic valve. So instead of having 3 leaflets, it's like 2 leaflets only. So occurs in 1 to 2% of population, usually asymptomatic in childhood. The majority eventually develop aortic stenosis or regurgitation associated with left dominant coronary circulation. The posterior descending artery arises from the circumflex instead of the right RCA. So posterior descending arises from the circumflex instead of the RCA, and Turner syndrome as well involved in that. Around 5% patients also have a coarctation of the aorta. Complications would be aortic stenosis, regurgitation, high risk of aortic dissection, and aneurysm from ascending aorta. The last few topics: tetralogy of Fallot and dextrocardia. Tetralogy of Fallot is the most common cause of cyanotic congenital heart disease. What is the other cause? TGA, and that's like during birth. It typically presents at 1 to 2 months, as I've said before. All the may not be picked up until the baby is 6 months old. Four major characteristics are, as usual: VSD, right ventricular hypertrophy, right ventricular outflow obstruction, pulmonary stenosis, and overriding aorta. Severity of RVOT determines the degree of cyanosis and severity. You have to remember this. Other features would be cyanosis causing a right to left shunt might occur, ejection systolic murmur due to pulmonary stenosis. The VSD doesn't usually cause a murmur. A right-sided aortic arc is seen in the 25% of the patient. Chest X-ray shows a boot-shaped heart. Of course, you'll see like a boot-shaped heart. ECG shows right ventricular hypertrophy. Surgical repair is often undertaken in 2 parts. Cyanotic episodes may be helped by beta blockers to decrease infundibular spasm. However, at birth, transmission of TFGs, as I've said, is the most common lesion. What is dextrocardia? It's a rare common condition in which heart apex is located at the right side of the chest. So you'll see something like this, like there's lungs and there's this heart like this instead of that side. Okay, so sometimes it's associated with situs inversus, in which most organs are like reversed or mirrored. So for some people it's just dextrocardia. What do you see in ECG? Inverted P waves in lead 1, shift of the P axis, and reverse R wave in progression. Reverse placement of the pericardial leads on the right chest at sides corresponding to the left chest corrects the trend. So when usually put the chest leads like this on the left side, just instead of that, if you put it on the right side, it will be fixed. The changes in ECGs. Typically, patients have a normal life expectancy if no cardiac abnormalities are present. And then comes patent ductus arteriosus, PDA, as I have said, an unexpected increase in oxygen saturation between the RV and PA, associated with high pulmonary artery pressure and high wedge pressure. So this is like basically for part 2, and that's like cardiac catheterization reading, like which side has more oxygen, which side has less oxygen, the percentage is there, and yeah, that's it for cardiology. Hope you like these videos, and I'll be making videos for all the systems, so check out the videos. And this is basically not for explaining all these videos, it's just a revision of everything that's there. If you have already studied everything till now, this videos might help you to revise. That's it. Okay, take care.